Thank you everyone for joining in our first webinar. Most of you, probably all of you know me, Clive Savocool with LogRx and paramedic myself. And so we wanted to start hosting some quarterly webinars, kind of like when we send out our newsletters, just to keep people abreast and help our customers out any way we can. And something that we found super helpful was getting to know Dennis Wichern, who's a retired DEA Special Agent. And so he's been helpful with us in our business. And so we figured we'd host a webinar to share that. So before we get started, I also wanted to thank the Carlson Center. We have Cameron Law with us. The Carlson Center is an innovation group with the division of the Sacramento State University, about a mile from where our office is. And so they've been instrumental in helping our company as a startup grow. And then Dennis is the retired special agent with the DEA who's with us. And I'll let you introduce yourself, Dennis, or your
Hey,
background.
thanks, Clive. Hey, it's a pleasure to speak in front of you today and work with Clive on this podcast. As Clive mentioned, I'm a retired DEA special agent. Lucky enough to get the job back when I was 30 years old. Uh, Worked there for about 31 years, working around the Midwest predominantly, worked in Indiana, Missouri, Washington, D.C., and Chicago. And ever since I retired around 7 years ago, I've been helping out DA registrants, hospital clinics, pharmacy, pain providers, methadone clinics, EMS services, veterinarians, and the like on DA regulations, trying to make it easier for those professionals that work with the drugs every day. So that's what we're doing today, and I look forward to working with you today, Clive. Back to you, sir.
Excellent. Thank you. And so as we're going, I know the invite, I think said we go till 3 p.m. Pacific time, but we're going to keep this to about an hour. We might go over a little bit. So the first 45 minutes or so, we're going to go through a series of questions I have that some people sent in. And then if anybody else has questions for Dennis, drop them in the chat. And then Cameron, who's our moderator, can go over those at the end. Or if there's a question on a response Dennis has to one of these questions I've got, feel free to chime in, and he'll and Cameron will pipe up and and answer those questions. So we want to keep this somewhat informal, just so everyone gets the most out of it. Because the whole premise of this, having been in a first responder since the 90s, it's always been really hard to get direct information from the DEA. So we want to make the most of this for everyone. So, all right, here we go. The first question. What are some examples of mistakes you have seen medical providers make with handling controlled substances or handling them in general?
Yeah, common question, Clive. Probably the number one thing I've seen from my years on the job is just lack of training that anyone's given to medical providers if they maintain drugs at their clinic, wherever. And oftentimes they don't have the records required that are required to maintain those drugs. So really, that's probably the number one. Number two would be, well, one would be lack of records, general lack of records, and then just poor record keeping, where the drugs went, who they were administered to, where they ended up, and things like that. Uh, with that being said, sometimes many medical providers, especially the doctors and the NPs and things like that, they think the only records they need is in the EMR or the EHR, whatever your state calls it. Hey, I have all my records in the electronic medical record. That should be good enough. Well, that isn't the way Congress wrote these regulations that DA's got the authority to do in right around 1970. And then lastly, two other important ones on that vein is poor security. I'll give you some war stories there. The DA regs, that's what I'm going to refer to as the regulations one must abide by and be held accountable if you maintain controls, also encompasses just general security of the drugs. So war story wise, there was one provider that would keep hydrocodone in her office, and she'd just keep it in a grocery bag in an unlocked file cabinet. Another time, a provider kept drugs, but he'd leave his prescription pads out in the office. And then the other one I've seen is sharing passwords that maybe somebody shared to get access to a safe with the drugs. So, the list goes on, but you want to have a common sense security protocol Things are going to happen at times, but you don't want it, where everybody's got access to the drugs because things can go south pretty quick. And then I'll wind that answer up, Clive, is nowhere in the regs is training or policies mentioned or written. You'll never find that in the DA regs. However, when they're often a part of what you should have, and that's the part you find providers just don't have policies or any training for their staff how to handle the controlled substances. So those are probably the top four I've seen in my career. Back to you, Clive.
Excellent. Thank you. And I should say that probably in a lot of EMS agencies, I know fire department I worked at for most of my career, our password to get into the narc safe was our employee number, which is public record. So it our practices have definitely been a little lax, as providers in general. Okay, let's see. A lot of EMS agencies, including all the ones I've worked for, have often struggled to get information directly from the DEA. It seems very difficult to engage, just to get some direction. It's really hard to get a hold of folks from the DEA themselves. And so we're just curious if you can give some background on why EMS providers have the kind of that block.
You bet. Another common question. It's primarily because of the culture of DEA. And when I talk about the culture of DEA, DEA's got about 9,000 employees. Most of them, and the leadership is all special agents like I was. DEA agents run the agency, and their primary focus is Mexican cartels, illicit fentanyl, gangs, meth labs, coke traffickers, and the like. And that's where their bread and butter is. But when Congress made DEA in 1973, they also threw in this other part that oversees the pharmaceutical controlled substances like EMS, specialists used every day to help treat their patients. Doctors do NPs and PAs. But since the DA agents run it, they're more kind of similar in their thinking to like the CIA. So they're not used to telling people what's going on and things like that because they operate behind the closed door. However, the little part of DA, it's about 700 people that oversee the regulatory portion. They do, but they're managed by agents who have kind of a CIA culture. So it's kind of a culture. I think DA's getting better at it. Uh, or at least I hope they are. I always tried to be once I climbed the ladder because I recognized it too. There's just a lot of questions by medical providers, and they need to be answered by DEA. Now, a couple tricks that could maybe help an EMS specialist professional out there. One is to call the local registration clerk in the big city near you. So, for instance, in Sacramento, there's probably a registration clerk there. If not, there'd definitely be one in San Francisco. And there's about 60 of them across the country, and their job is just to help DA registrants with their licenses. They're not the investigators, they never leave the building, but they're more prone to answer some questions or try and run down information. The other two I want to mention is the other one, DA's written four manuals and updated all four. And they're manuals you can get on the website. There's not a specific one for EMS. However, the four manuals are a pharmacy manual, a practitioner manual, an OTP manual, and a researcher manual. The closest one as a point of reference that could help an EMS specialist like yourself is the pharmacy manual because they dispense drugs, whereas EMS would actually administer drugs, but sometimes DA calls those the same thing. But that'd be a good point of reference for some of the things, and I'll reference that in later questions. And then lastly, there is an email that anyone can email DA headquarters, the policy section, to try and get a question answered. Now, generally, they will respond. I've done it since I've been retired. Sometimes they don't respond. But that email site is DPY David Paul Young at DEA.gov. David Paul Young at DEA.gov. And if you ask them a question, they should reply back to you. Just might take a while. Back to you, sir.
Thank you. Yeah, and we can get that email dropped into the chat before we're done. Um, And just, I'm going to skip ahead to another question just because that kind of the contact with the DEA brought up another question in my mind that there's a concern about talking to the DEA and then kind of exposing yourself. And a perfect example is I talked to the DEA a few years ago when I was a fire chief, and I wanted clarification on the proper disposal of expiring narcotics. And when I mentioned that our medics would just squirt it on the ground and then they would document a waste and have a verifier. And the first thing she asked is, wait, where do you work? And so it was like instantly my brain's like, oh, great. I just put our fire department on the map with the DEA. And so the question I had later on, I'll ask now because it's pertinent, is if an EMS agency self-reports a narcotic discrepancy or diversion, how is that typically received by the DEA? So is there leniency because you're coming forward to say it's self-reporting, or do they just say, all right, you made a mistake? Like recently, San Jose Fire Department. If anybody Googles San Jose Fire Department right now, they're going to see that one of their firefighters was stealing drugs. And so if San Jose Fire self-reported, how is the DEA going to look at me if I self-report basically as a fire chief or ambulance director?
Yeah, that one cuts both ways, Clive. Sometimes by doing that, you could get a DA response. And what I mean by that, uh, if it's they could respond within the next day after you report it to your fire station and want to do an audit of everything. So the reg says you have to report a significant loss or theft within 24 hours of notice. Okay. But it's up for somewhat of interpretation. So if you're ever forced to report it, tighten up all your records. Stuff happens, like you say. There's always going to be somebody diverting drugs in America. It happens every day when you're working with the fentanyls and the morphines and the Versed. I mean, it just happens. But to have tight records, a good system, but you do need to recognize that. Uh, and if your records are good and everything, you should generally come out fine on those. But there is a risk when you report some small things you shouldn't report. And then what you mentioned there about wasting, the wasting regs are a lot clearer now than they used to be. I know I work with a number of ambulatory surgery centers, and they used to commonly waste into gauze pad. So, yeah, are there's DEA regulators, these investigators? Do they have heart attacks over some of these little things that happen in the field or on the street? Yeah, they might. But uh, in the same regard, kind of common sense. But we'll talk about wasting and destruction. It's a lot simpler now. It was a little more unclear back then, though, too.
Yeah, the direction she gave me was if you destroy it in-house, document it, and however you destroy it, it can't be reconstituted to be that substance. And so there's a chemical out there, I think it was like RX Destroyer or something like that we were using at the time. But anyway,
And,
that was the context of how much do we pop up on the radar.
yeah, I know you probably asked me, where's EMS on the radar? I'll answer that down the road. But use an RX destroyer, deterrent, or pill buster is the accepted way nowadays. And the DA definition they came up was you have to make it non-retrievable, and then you just have a witness. So it's fairly simple. There's other ways to destroy drugs, but keeping one of those containers, if possible, on one of the EMS vans, trucks, or whatever is the same way people do it now in the hospital and other places. So that's kind of the general industry standard. You waste and destroy into those containers.
Excellent. Thank you. Let's see. The next question is, what are the most common misunderstandings EMS personnel have about the DEA's role in controlled substance oversight? Um, yes, is what have you seen that misunderstandings basically of expectations?
You got it. It really comes down to DA's exact authority. So I mentioned the little known fact, and people always kind of chuckle, but it's true. DA's authority is only record keeping and security of the controlled substances. And it's almost verbatim identical to what the Board of Pharmacy investigators have too in every state. So the authority that the State Board of Pharmacy that generally inspects pharmacies and other people that maintain drugs, DEA has that same authority. So they kind of copy and they work together real closely. Little known fact, DEA has no medical doctors, no EMS, no nurse practitioners, no PAs, no medical expertise at DEA headquarters or in the field anywhere. The closest we have is some SWAT EMTs, and DEA's been trained and carries Narcan too, like most professionals do. Uh, but if DA ever needs a medical opinion, they have to hire like EMS or like a doctor. And the general case is hiring a pain doctor to review another pain doctor. I've never heard of DA ever hiring somebody, an EMS, to give an opinion whether Clive did the right medical procedure, dosed the patient or the victim or whatever uh, that person is that needs your help with the correct medication and the correct dosage. It just wouldn't happen. But I think that's the number one thing. DA's authority, and I often say, and they're bean counters. This group is bean counters. They just want to be sure you have records where all your drugs went, okay? And you keep them fairly secure, and the security is somewhat subjective. Uh, and you know what? And I'll wind it up with that. DA has no expertise, training, or the authority to give an opinion whether an EMS person dosed or treated the victim or the patient, I should say, the right way. So record keeping is security only.
Gotcha. Yeah, as paramedics, we all work underneath a medical director for our local EMS agency, and so they're usually the ones that are going to scrutinize us if we mis mistreat a patient with a drug or something. Let's see. Can you walk us through a DEA inspection or an audit of an EMS agency, what it might look like? So say we had a diversion, we self-report. What can we expect when the DEA shows up? And actually, what are some triggers of that aside from a self-reported diversion?
The usual triggers is a complaint, but it's generally some information, and it could be from a DA 106, and that's the form you're required to use when you self-report a loss of drugs. So you mentioned like San Jose. Uh, you have in a perfect world, you have to report it to DA, and that's the only form you have to report to DA. All the other record forms never go back to DEA. They're maintained on site with your drugs. That's where to keep them. Okay. But if there's ever a loss or a theft, you have to report it to DA and generally to the same state overseeing agency. So I kind of broad brushed into the Board of Pharmacy, but that's usually who it is, unless there's another entity named in the state. So that doesn't always mean DA is going to come out. It really depends on the amount of drugs, how busy they are, and and how busy that office is or the culture of that office. There's only about 400 DEA diversion investigators that do these audits or these reviews, and they're spread out across 50 states. So when you think about it, there's not a lot, and they're mostly in the bigger cities. So the more rural you are and the farther away from a big city, the likelihood of DA ever knocking on your door is small. But to answer your question, let's say there was a significant loss like San Jose or whatever, it's reported. DA would maybe respond, and it's always subjective to that office. Uh, and it's
I got you. 1,400.
okay. And it'd be 2 to 4 investigators coming out. Okay. And they will not let you know they're coming out ahead of time. They're just going to show up and they're going to knock on your door. They're going to give you a form. It's called an SF 82, and it's consent to search and do the audit. You have the right not to do it. However, to get a DA license, you sign away your right, though, too. So if you don't acknowledge letting them in, all they got to do is go get a warrant to get there. So that's one of the catches to have a DA license, the way Congress wrote the law. They're going to sit down, and hopefully you have one point person in your office that understands the records. They're going to want to see where you keep the drugs and your security. They'll talk to you about that. They're going to ask you about your last biennial inventory. And that's this catchy word I had to learn by DEA. You're required to keep an inventory, which is a snapshot in time of what you had on hand on a particular date. And you're required to do it every other year. Then they're going to say, hey, please provide us your last 2 years of invoices and DEA 222 forms. And that's your forms where, the receipts of the drugs you ordered for your vials of fentanyl, your morphine, your Versed, and any other control. They're going to have one or two people then go in and count your drugs with you on hand, and then they're going to do the math, and they're going to ask you too. I forgot to throw it in. They say, hey, I want to see your dispensing records. And in EMS language, I believe you'd call that dispensing, or you'd call it your administering records. And they're going to want to see those for 2 years. And they're just going to add all that up. And then hopefully, if you're running good records, it all matches with what you have on hand at that time. So that's really what it entails. Most times when they go in a pharmacy, it takes around 4 hours. I would think in an EMS with an office and things like that, it'd be a lot less because you wouldn't have the large number of drugs. But you could though. But generally, everybody I've talked to has heart attacks when they show up, but they're just checking numbers. And that's why I often advise people, hey, get your most extroverted person out in front and one or two people that understand your records and have them readily retrievable. When Congress made these rules, they invented a couple phrases, or the key one is they must be readily retrievable. And that means that you have to produce them generally in 2 to 4 hours. So you need to keep them on site where you're at. You cannot keep them like at headquarters an hour away or anything like that. That'll piss people off. So you want them all condensed right where the drugs are kept, and then somebody that can explain them. And then hopefully you've got your protocols and you're following all the little rules that DA requires. So for instance, there's 8 items that must be in the dispensing regulation. You can go above that, but you got to have the minimum 8. And then never forget the DEA people, it's subjective too. So if you get 8 out of 10 right, you're probably going to get a pass. Okay. The people that don't get a pass usually have 0 out of 10 wrong, and they just have no records. But that's kind of the quick synopsis of that, Clive.
That's great. Really good information. Yeah, and for all the attendees, if you're ever audited, you can call us day or night. We help with whatever records you need to pull out of LogRx. You can pull them out yourself in the reports, but we had an agency in Colorado get audited, and so we worked with them real time so that those records, pretty much everything that the dentist just listed, aside from DEA 222 numbers and invoices, we can help get all that for you. So just to keep you in good graces if you're ever getting a DEA agent at your front door. Let's see. What are the most frequent DEA violations you've seen among EMS agencies, and what consequences typically follow?
The number one is failure to record a biennial inventory. And as I mentioned, that's a snapshot in time. I tell all my clients, it's like, hey, do it every year. If you're trying to remember, okay, did I do it 2 years ago or the other 2 years? Just do one every year. It only takes a few minutes to do one, and it has the same required 8 items, and you got to have a witness. And the one thing you got to remember on an inventory is you have to do it either at the beginning or the end of the shift. Okay. But that's one. Failure to have a power of attorney. I call this one a little dicky-do one, and Congress made it. At times, to me, it doesn't make any sense. But a power of attorney is granted from whoever's name is on the DEA license / the DEA registrant. So let me give you an example of that. The CMO, maybe the CMO or the hospital organization has the DEA license for the EMS service or an extension of. According to the way Congress wrote it up, he or she that got that license is the one to grant a power of attorney. Or, if I'm going off memory, off the regulation, another corporate officer. And then all it is a form that allows, let's say, for an example, Clive, that the hospital in Sacramento gave you the authority down the line to order the meds you guys needed to treat the patients. So you just want to keep this power of attorney be signed by them, giving you the authority to order the drugs. Okay. And that only applies to Schedule 2s, but I know enough about EMS that you're always going to have some Schedule 2s. I've worked with some other pain people. They don't do 2s, they just do ketamine and Versed. They don't need a power of attorney from anybody. But it's only 2s. Why they only did 2s, I don't know. Probably because the 2s are always the most diverted. Uh, Moving on. So we have the inventory, the power of attorney, and then the failure to keep the invoices and the paperwork when the drugs come into your office. People shred those, throw them away. All of the federal rules are you must maintain all these records for a minimum of 2 years. And I believe California is actually 3 years. And there's a little known reg out there. And it's actually a good way the way the feds and the state work together. Whoever has the more stricter of the rules, state or feds, you got to go with the stricter of the rules. Okay. I'm almost certain California is 3 years. And then as far as outcomes, let's say your records are perfect and it all adds up, or it's fairly close. And the one advantage EMS is going to have with the liquids and the vials, it's much harder for DA to get an exact one-to-one count, as opposed to if you go in a pharmacy in a perfect world, they got perfect records. Those pill numbers, those tablets match up perfectly if they've got pristine record keeping and things like that. But when you're dealing with vials and things like that, there's always going to be some variance. But you got perfect records, and let's say POA, DA would probably say, hey, you ought to get one and have a nice day. If you don't have, let's say, you only have half your invoices and no POA, but your records are pretty good. It's like, hey, this is poor record keeping. I'm going to go talk to the boss, and we might send you a letter of admonition. And in DA speak, they call that an LOA, and that is simply like a warning speeding ticket. Hey, we came out on this date. We observed this. You were deficient here. Don't let it happen again. So it's kind of meaningless, but they're kind of building their, let's say, their evidence potentially against you if something went south down the road. Okay. Uh, and then let's say they came in, and this happens sometimes in pharmacies and some OTPs where nobody's been taught the records. They really have poor to no records. DA might move right to a memorandum of agreement, and that's like a 3-year probation period with DA where they come in and check your records every year. And then let's say you had a big loss. You could get a civil fine in the thousands of dollars. Haven't seen that often in EMS services. More prone to ambulatory surgeries and pharmacies where there's a significant amount of drug loss, and then DA will take that to the U.S. Attorney's Office, and then if they can convince a civil prosecutor to civilly fine you, they have the authority to fine you, but only those prosecutors have that authority. DA does not. So that's kind of, the spectrum. But generally, if it's minor, maybe nothing, maybe a letter of admonition. That's the most common response.
Thank you. Lots to unpack there. One of the questions that came up as you were mentioning that, and this is for a lot of our wildlife veterinarians that have asked us, is when they have, say, a set amount of a drug, when you talk about liquids, and say there's supposed to be 50 milliliters in this vial of this controlled substance, they get through it and they find that there's still a little bit less. Say there's 5 extra milliliters in there. We ran into this a lot with the COVID vaccine. It said 20 doses, we'd get more than that out of them. So for documentation purposes, we get questioned, how can we change this in LogRx? Because we got 55 milliliters of this drug, even though the vial says it comes with 50. What would the best case scenario be on how they should handle that situation in the eyes of the DEA?
I'm glad you mentioned that. When somebody else asked me that in the veterinarian professionals. They said, yeah, sometimes we get vials with more drugs than they say on them. And it's like, I know that would go generally, with all due respect to my former DA people, right over their heads, because in everything else they deal with pills and things like that, it's all exact. Uh, so I think the best advice there is you get a witness and waste it, okay, and document it in some fashion. So, for instance, I mentioned wasting and drug destruction. If you waste, you got to have a witness and you have to document it. So it's oftentimes easier to do that on the same form that you're dispensing drugs or administering drugs with. And I know you can't do that. The other way is a DA 41 form, and that's the general destruction. A DA sees wasting different than drug destruction. But I know that sounds a little unusual even when I say it. There's a difference. I know you understand it too. So if there's anything left over like that, I'd get a witness, I'd destroy it, and just document it on a DA 41. If you can't get the DA 41 or you want to cut a corner, write an email back to yourself and put it in your files with your records. And I just say on this date, Dennis and Clive had 5 milliliters extra. We destroyed it in RX Destroyer on this date, and that's how we got rid of it. And then we just keep it in our records, and that would probably fly all day long for DA.
Okay.
But that's interesting. It's like that you actually get more. You don't see that generally on the other side, but you guys, I'm learning from you guys too.
Yeah, and my guess is the manufacturers would rather have a little extra than under the amount that's supposed to be in the vial. But that's good to know. Um, let's see. Kind of answered the next question. So just in case we have some medical directors that joined us, how can a medical director better support DEA compliance with their EMS agencies? And so, for example, when I was in Contra Costa County, the medical director, he oversaw, I think there was about 7 ALS agencies within the county. And so we all fell under his medical direction. He set our scope of practice. Um, and so from their perspective, even though each one of those agencies had their own DEA license, what would you suggest for a medical director in regards to managing DEA compliance?
Well, that's a great question because if anything ever goes south, they're looking at his DEA number. Okay. It isn't, you can't, with a DEA number and that person is the registrant, you can't pass the buck. He or she's accountable for those controlled substances. And uh, so I think that the top things that I would do or I'd always advise people do is like, all right, let's create some policies. They don't have to be extensive. They could just be 1 page, 2 page. And I'm sure you grew up with policies like I did in your profession, Clive. So make them simple to understand and user friendly. And then you adjust them every year, every other year for how you learn to make it easier on your men and women underneath you. And then two, just be sure there's some training because both of those help cover you down the road if something goes wrong. But in the same regard, the training's good, what he or she expects, and here's the record keeping. And then if I were that person, I would assign one of you as a leadership or get the head nurse that's good at everything, who's highly organized, and then you want one person to run the records. Okay, I can't tell you enough on that. It's like sometimes I've been in places and it's like Larry, and Curly point. It's like, hey, who knows how this works? And everybody's pointing this way. And I don't want to broad brush into the women. And I know there's guys that are organized too, but you want somebody to write herd over the records. Hey, you got your records in, you're doing monthly. And then I'd wind it up too as a perpetual inventory. It's not required in the DA regs. However, it's the smartest thing you can do if you're running controlled substances. And a perpetual inventory is nothing different than what we all expect from our electronic banking records from our bank. We can pull that baby up and we know exactly how much we have on hand at any point in time. That's how you want to run your controls. And then if something's messed up or somebody added wrong or this happened or that, you can fix it, clean it up, or address it immediately. It's a bitch to go back a month later and figure out what the hell happened and why are we off this or that. So that's how I'd say it. It's like somebody's got to take charge and at least just be sure the ship's just running right and the records are coming in. And DA will never tell you how to build your record system. They're just going to tell you what's required in it. So you can go above and beyond whatever you're taught with. Some people are all computer, some people are paper. I'm a little bit of both and things like that. So it's like whatever works is the way to run a great system that you guys believe in.
Excellent. Thank you. Just to kind of follow up on that, I think one of the big struggles in EMS, and probably even more so with the wildlife veterinarians, is they're spread out geographically. So I worked at a fire department with 30 fire stations. And so you're talking about, 60 miles from one station to the next furthest, or for wildlife veterinarians, they're talking hundreds of miles between different locations. And so you might have one person in charge, like one veterinarian or two veterinarians for the entire state, but they have lots of folks to work for them out administering and carrying these drugs. Um, so in that situation, aside from tight policy and tight record keeping, is there anything else you'd recommend for them?
Yeah, you know what? Three things come to mind on that and one of your early questions. Let's go back to overage, and I'll address that question. DA will never, ever, uh, they could never, ever prove overage, or I don't think they could, if you get, let's say, 5.5 milliliters in that vial says it's only a 5 ml. It's like DA could never address that other because whatever it says on the invoice is gonna be and whatever it says on the vial. So that's one. So, if it happens, it happens. Deal with it, destroy it, and cover your flank. Uh, as far as like your question there, Clive, I'm thinking, okay, if I was out there, how would I do it? Maybe I don't have a witness to destroy drugs or waste drugs. So it's like, I'd pick my phone up, and if I was extremely cautious, I'd just video it to make a record, and that's the record I'd use. Now, is that okay by the regs? Not that I can tell it is. The reg says this, but keep in mind one thing, guys. Those regs were made 50 years ago in like 1971, and they've kind of changed, but it still comes down to common sense and things like that. And in the profession you guys are in, uh, it's like, hey, you got to take care of the job too. So you're going to get what I call the push at times, just like I did in my job. Sometimes the regs just don't fit real life, but there's ways around it and things like that.
Well, it's like if she was in VTAC right now and she looks good, she's got
And
normal.
so that would be the way I'd answer that one. It's like do the best you can. Uh, all DA primarily cares about, do you have a record where the drugs went? Sometimes you don't have to explain it all the time as long as those records match too, guys. Okay, but we got to follow the rules. But real life's real life, and government regs are this. Sometimes you got to meet in the middle.
Very nice. I've got one more question, and then Cameron has opened it up to the group. So I'll ask mine really quick, and then we'll jump to the group's questions. So I think Cameron solicited it in the chat. So if anybody else has some questions they want for Dennis in the remaining 20 minutes or so, please throw it in there. So my last question is, how does the DEA typically communicate regulatory updates for EMS organizations? And is there a good way for us to be proactive to stay informed?
Yes, sir. Uh, historically, DAs communicated poorly, and it goes back to, like I say, DA's more like a CIA culture. It's like, and I still don't totally understand what the CIA does. But we do have the regulatory side where DA's got to get better and be more overt. A couple things DA's done on their website. They revamped their website and for a while was a pain to move around. But they have a section called What's New, and that's something you could check too. I'm signed up on diversion updates. It's actually an email you can sign up for, and when DA diversion posts anything new, uh, it'll come right into your email. That's one way. And then the other one I learned from a colleague of yours, uh, every now and then DEA will update some of these regs. And keep in mind, when these regs were made, as I mentioned, 50 years ago, they didn't totally think everything through. They thought about hospitals and pharmacies, but they never really addressed like EMSs in the regs. Okay. They never addressed uh, mobile pain providers or veterinarians who take drugs out in the field like you professionals do, Clive. Uh, and they're getting better at that. They use a framework of records and then they apply it down and kind of tweak them. And nowadays doctors are allowed, and it's not in the reg, to take drugs out to a site to administer to a patient. And the veterinarians actually got the law changed 10 years ago to allow them to do it, even though they were doing it, it was never written in the regs back in 1971. So my point there is uh, they're actually coming out with EMS regs down the road. Usually DEA is slow as you know what to get any reg out. Okay. And then they have to post them and they got to take comments. But at least on the web page, DEA's finally addressing the EMS regs that hopefully make your guys' job easier and things like that. So really the best I can say is look on the website or sign up for the emails. I get these emails, but they do come in spotty. Uh, and then you guys can kind of use me. I usually stay current, but every now and then I get taught by somebody else something I missed too.
Sounds accurate. Yeah, we were told about 3 years ago at a conference in Orlando that digital tracking in narcotics was happening within the next couple months, and that was 3 years ago. So you can see how slow things progress on our end too.
Yes, sir.
So we got a good question here. This one is regards to wasting drugs with hard copy versus digital tracking. The question is there a preference as to which form should be used with wasting drugs and getting signatures for the waste? Hard copy form or the forms within an electronic health record? We use them PCRs, patient care reports. And so for the record software they use, there's an entire field for wasting controlled substances, but they're still using a hard copy so that they can get the wet signatures and keep them on hand. And so the question is, we're trying to go away from paper, but is a hard copy something that you recommend versus using just the electronic PCR program?
Yeah, that's somebody that knows the regs well. And that's where I kind of preach if you can ever do it, I call it going left to right. It'd be your dispensing, you're administering all the items you need. And then if you waste or do you not, you have them all there. But that's if you're using paper. Uh, I would think if you have perfect records and you're dealing with a common sense DA person, not a hard right one, that all electronic, and if you can prove up the signatures or however you do it electronic, you would probably get a pass. But just like that person that posed that question, the reg says you need the name and the signature. And to keep in mind, it goes back to what I was saying. These regs are kind of stuck in time warp from 1971. Uh, I hope that kind of helps. I mean, if you're tight on your stuff, I think you could do it electronically and nobody would give you any trouble on it. But I do know what the reg says, and the reg says a signature. So if there's some way to meet in the middle, that would be the best way to do it. Because I got to admit, if all you're administering, and you can do all your administering or your dispensing electronically, and that's where this reg hasn't kept up with time. But if you waste, they want, a wet signature, but you don't need it for your dispensing administering log. So it's confusing. It needs to be caught up, and that ought to be brought to the attention of DEA. But if you want to be super cautious, yeah, you ought to do paper. Could you do it all electronic? I think you could, and nobody would blink an eye as long as everything else is tight. Okay.
Excellent. Yeah. And we've gotten, I mean, we've been in business for 5+ years, and any audit our folks have been involved in, which is electronic, they've always been praised. So I think that's reinforces what you just said about tight records. Let's see. Next question is, has there been any clarification on controlled substances being kept at multiple stations? We were told that we could not get a DEA number because we were keeping controlled substances at 2 stations. And so just some perspective, a lot of fire stations, some fire departments who have multiple stations will have a drug safe at each station for restocking their drugs on the ambulance or fire engine. And so in this context, and I've heard this before, where the DEA says, if you have multiple locations where you're storing drugs, they need to have independent DEA numbers for each location. This question specifically, and that's not consistent. Some agencies have narcs at every station and they only have one DEA number. But this specific question was, we were told we could not get a DEA number because we were keeping drugs at 2 separate stations.
Right. Hey, and hopefully these new regs, but as you mentioned, would clean that up. But sometimes DEA stands for don't expect anything either at times. So it's like how long it takes. As a general core rule of DEA, and this is like big brother watching little brother, anywhere drugs are kept needs a DEA license / registration. And I use them the same. When I say registration license, I mean the same thing. That's been a core rule of DEAs since 1971. However, I see the common sense, as you mentioned, DEAs kind of lightening up on that through some other professions. So, for instance, because of the opioid crisis, the methadone clinics that most people call them OTPs, opioid treatment providers, they can go mobile now, something that you guys take for granted in your profession. So what the clinics are doing, they can take methadone out in the field with them to treat the OUD patients in the field, and then they got to drive it back to what I call the mothership every night. I don't have a good answer for that one. In the real world, where the real world meets the regs, it makes common sense as long as you got records. But in the DA record rule, you always are registered wherever drugs are kept. DA wants to know exactly where they're kept, so that way they can later do an audit. So hopefully they'll clean that one up. I'm almost certain if you would email DA headquarters at that email site I gave you, they're going to stick to that because that's always been one of their cores. And then I'll wind it up with, I don't think they'd ever do it to EMS because, they look at you guys as, highly noble and, like another first responder where they don't really want to ever mess with you guys. But for instance, there was a big top 10 teaching university in the Midwest that had like 15 ambulatory surgery centers not registered in its teaching university. And I don't want to front these guys off. You guys could figure it out. It's in the Midwest up by the Great Lakes. And they find those guys like, I think it was 2.4 million because every time a drug went in there, it was unregistered. And what happened that brought it all crashing down is a nurse and a resident were stealing fentanyl and they overdosed. One died, the other one, they were luckily to bring it back. And then that brought in DEA, and then they found all these unregistered locations. But I want to stress, I don't see them ever wanting to touch that one with EMS. But as a core general rule, wherever drugs are kept, that site should be registered. But it makes common sense why you want to have that many DEA numbers out for probably what's just a small kit of drugs. Okay. So
Thank you. Yeah. And from my experience, the locations were all labeled as mobile. And so we just had one DEA license for the agency. And then each location, even if there were some drugs kept in the firehouse, they were assigned to that fire apparatus. And so that's how we got around the
let me
having
add
that.
something to that, Clive. It's like, here's another one where that's great to hear. So it's like DEA, after the veterinarians changed the rules, but they just got it put into law back in 14 where they can take drugs out to the farm, wherever they need to treat the animal. DA started allowing what they call the black bag, and it really applies to let's say CRNAs and mobile anesthesiologists who support like dental surgeons and things like that for surgeries. Okay. And then it's nowhere in the federal regs, the D/DA regs, which are really the federal regs, the Code of Federal Regulations, do they allow that. However, DEA granted it by doing, lack of a better word, the right thing, where it allows people to do that. They take it from what I call the mothership back, as you mentioned, and then you keep records. So if you're going to do that, keep your records pristine and you won't lose that authority. So it's good to hear that they gave you guys the pass on that.
Yeah. Let's see. Here's another one. For us, the DEA registrant is in the field frequently and not in cell service. Beyond cross training back at the office, is there an appropriate person? Is there appropriate person? What happens if there's an inspection and the registrant is unavailable for hours to days? So it sounds like a reporting issue where they're unable to get a hold of their local DEA register, or actually their DEA registrant is in the field.
Right. You know, in the history, I've seen very few uh, EMS audits or responses. The odds are small, but that would potentially could get DA mad, but there's nothing to say it couldn't. I helped out one of these mobile anesthesiologists, and he only worked like 3 days a week, and then DA called him. He says, "Hey, I can't meet with you for another week." So the point of it is, uh, because these inspections sometimes are subjective, you always want to treat Big Brother as nice as you can. The only answer I'd have there is it's like, hey, is there any person else that you can train that sits there that knows the records? You have them all saved, like on your system or some other means that can kind of cover you till you get back. And sometimes you can say, hey, I'm in the field, I can meet you on this date. And I've seen DA accommodate that. But the DA diversion investigators, it's the way the law is written. They can show up at any time during business hours and they don't call generally ahead of time. Okay, so it's like if you can plan for it, fine. But if you can't, they're going to have to meet you when you can meet them. It just is what it is, and I've seen that happen.
Excellent. And just for everyone who's attending's sake, I'm assuming most, if not everyone here, is using LogRx. As long as you have an admin on your account that calls us, we can help with getting any kind of records for you within your account too. It just has to be an admin. We won't give any records to any non-admins. So if your registrant is unavailable, goes on vacation, whatever, we are always able to help as well, day or night. So that is it for those questions. We have time for maybe one more, if there's any from the group. Otherwise, I actually had a couple more on my sheet. Actually, in regards to the DEA license itself, I'll ask that question where basically some states like Pennsylvania and Virginia, a lot of the ambulance companies, they would go to the local hospital pharmacy and the individual ambulance would go and restock when they needed more controlled substance. And basically in those two states, a lot of the hospitals are saying, we no longer want to be your DEA license. You now have to get your own and store your own drugs. So I think that the question would be is, what's the background on hospitals being the DEA license? And is there pressure from the DEA telling them, hey, we want you to knock it off, give it to the local agencies? Or is this something you think is just a state issue or being pushed by individual states?
Yeah, I think it's maybe a combination of both. Uh, I don't think DA's pushing that. There's another one of these goofy little federal regulations. But you guys would be the exception in your profession. But the goofy reg is a doctor, a pharmacy should never fill an open stock of drugs for a doctor. Okay, a doctor can't write a prescription to a pharmacy for, you know, 500 vials of morphine or whatever. It's always got to be patient specific, but there's been occasions in the past. Now, a pharmacy does have the authority to sub-distribute to, they can sell drugs to you guys, and that's allowed by DEA. And you can go up to 5%. And this is another one of these squirrely rules. If you go over 5%, that pharmacy's got to get a distributor license, and it costs a lot more money. Okay. But you can distribute up to 5% of your stock to someone else. But there's a catch on that too, because all the opioid stuff, then you have to look at their ordering and be sure they're ordering correctly. I just know too, and I defer to your expertise and your clients. It's like this part's like the EMS challenges where in 1971 they wrote these regs and they never thought of the special needs of EMS and how to do it through a hospital or through a CMO, because I know there's private EMS services out there and they're just ran by they get all their drugs from the provider's DEA number. I think the best option if the pharmacy's shutting it down is you got to find a medical provider, because every medical provider has the authority to order drugs, and that'd be your only option. But that's what I'm just hoping, Clyde. These EMS regs simplify it, make it simple, and things like that. And I'll wind it up with another little known fact: as a medical provider, about half the states, if you get your medical license, you have the authority. You got your medical license and you have the authority to prescribe controlled substances. In the other states, in the other half of the states, you need two licenses: your medical license and then a second license that it gives you the ability to prescribe controls. So sometimes these state issues are just grounded in history and the way they do things. Hopefully there's a fix on that one. And why they're not doing that, I don't know. It could be because of the congressional rules on suspicious order monitoring. And this is a result of the opioid epidemic, that if you sub-distribute, if I run a pharmacy and then I distribute drugs to Clive's EMS, I then have to institute a suspicious order monitoring system, be sure you're not doing anything questionable in what you're ordering. And questionable would be like all of a sudden you shift to pills as opposed to liquid. So could be that, you know what I mean? This sometimes the increased compliance might be part of this. Law of unintended consequences, possibly.
Excellent. Well, we are just about out of time. That's all the questions I had, and I think we hit all the ones in the chat. So yeah, I think we're good. I just want to say thanks everyone for attending. Dennis, can't thank you enough for being so informative for us. Thank you, Cameron Law, for helping moderate. Dennis, is there anything else you want to? Actually, we'd love to get Dennis's contact information out there as well. So I don't know if you want to put in the chat, or if somebody wants to reach out to me, I can forward it. Everyone here probably has my contact info, but I'll put my email in the chat. Yeah, reach out to me. If you want a one-on-one with Dennis, you want to reach out to him specifically, please just let me know and I can put you in contact. Obviously a wealth of information. Dennis, anything else you want to close out with?
No, not really. I'd only say this, guys. I mean, uh, you know, software like Clive has developed is smart today. Uh, Anything to make it faster, better, more accurate, as far as if and when DA is ever going to go electronic. DA's gone all electronic. You can't send paper into DA anymore. Even the loss of drugs has to be an electronic. All your registrations have to be electronic. So there's probably a day sooner than later the DA is going to require that. I've been gone 7 years. I have no real insight. But when you think about we all accept electronic banking and everything else and things like that, it's probably only a matter of time. And I'll wind it up with that.
Excellent. Thank you. Yeah. You brought up policy earlier, and I'd say from a first responder's perspective, policies for us are like spreadsheets to an accountant. So all that information is great. Excellent. Well, thank you, everyone. I'm going to sign off. Any follow-up you need from me, please just send me an email, but really appreciate you attending. And if you have any requests for future hosts on webinars, please let me know if there's other topics you'd like us to do for each quarter. So thank you very much.
All right. Take care, Clive.